say single blood sample may not be diagnostic. Now, if I took a single blood sample and it were 5 times the normal range, that's all right. But you have to do that, okay? Well, what test should you run at this time to confirm your diagnosis?
The high dose test.
Everybody goes, which one now?
It's a high dose test. Oops.
Remember, in the horse, the high dose dex does not work. Because remember, it's the intermediates and it won't respond, and the primary won't respond. But remember when we talked about the TRH response test? And basically, if we run that, that's that tier in there. Primary pituitary adenoma cells lose receptor specificity for hypothalamic releasing hormones. So TRH will stimulate those corticotropes and increase their ACTH production even more. Okay, and so basically, that's what you're going to see. All right? And that explains it in there. You perform the proper test, and Spunky's blood ACTH level increases to 3.5 times the baseline level. Does this confirm your diagnosis?
Yeah.
And that does, because it's already up there, but that's high. Baseline's high, but you get it, it's gone up even more. Okay? And basically a 3-fold or greater increase in the blood ACTH level after the administration of TRH is diagnostic for PPID. In addition to dietary management of Spunky's condition, what's the most recommended drug treatment? Don't remember that far back, huh? It was only about, what, 10 minutes ago? Remember paraglide, racin, which is a dopamine agonist. Okay. So we clear on Spunky? What change probably has occurred in the horse's adrenal glands? Hyperplasia or hypertrophy? What lesion is probably present in Spunky's pituitary gland?
What lesion?
In the pituitary gland.
Oh,
A neoplasia. Okay. If we had atrophy of the pituitary and atrophy and hyperplasia of the adrenals, where does it tell you the problem is? In the adrenals. Okay. Let's do Scooter and we'll take a break. Scooter, female man. Oh, doesn't Scooter look beautiful? Somebody did a fantastic clip job on Scooter, didn't they? This miniature poodle female comes to your clinic with a complaint of progressive weight loss and increased food and water intake, pendulous abdomen, as you can see, and a bilateral alopecia that has spared the head and feet. You run a CBC, clinical chemistry, and your analysis here is our CBC. Again, all you have problems is with the leukogram, right? And how do you interpret the leukogram results? Stress. Remember, the dog can have a monocytosis in a stress leukogram. Okay. All right. Well, what about your analysis? What about that specific gravity? That's hypostenuric. Oh my heavens, we don't have problems with the adrenal. We've got diabetes insipidus, right? Do we have nephrogenic diabetes insipidus? Due to what? Glucocorticoids blocking the receptors. Is that a form of nephrogenic diabetes insipidus? Is there anything wrong with the ADH though? No, it's just that it's, receptors are being messed up. Okay? So that tells you why that urine specific gravity is low, because you are interfering with those receptors. All right? What about our clinical chemistry? Alpha, GGT, and ALT, what are they?
Stress.
The stress-induced liver enzymes. What about cholesterol? Does that go along with this problem? Mobilizing fat because the satiety center thinks we need more glucose? What about our glucose? So how come I didn't have glycosuria? Renal threshold in dogs is about 150 to 160. We may not be, maybe, that will vary with the individual, so we may not be reaching renal threshold. Okay? So what is all this telling us? Do we have liver damage yet, or do you think it's not gotten to that point yet? AST, if we had liver damage, wouldn't we have elevated AST? And we don't have it, so this tells us now, that doesn't mean I'm not getting some early damaging these cells, but it's not to the point where it's causing any problems with the function yet. Everybody follow that? Okay. And that's basically what it tells you there. So, you suspect Scooter has hyperadrenocorticism. You run a low and high dose dexamethasone suppression test with the following results. Baseline concentration 10. Normal is 0.5 to 6. 6 and 8 hour post low dose dexamethasone suppression test levels are 9.5. So does that confirm hyperadrenocorticism? Remember, a normal animal should drop it below 1.25. That doesn't tell you which one it is, it just tells you you have hyperadrenocorticism. It just tells you you have hyperadrenocorticism. What about what does the high dose do? It differentiates. Well, 8 hours after post high dose dexamethasone, they're 9.5. So high dose dex, what should you do to a pituitary secreting tumor that's responsive? It said decrease that cortisol level by at least 50%. Did we? So what have we got? Pituitary dependent hyperadrenocorticism. Everybody understand that? If you don't, please review it and everything, but that's the whole gist of what this stuff is supposed to be for. Okay? Diagnosis, right? So these results support a presumptive diagnosis of? Can we rule out A? Can't rule out A, can we? Can we rule out B? If it were responsive to negative feedback, what should it have done? About 50% or greater, did it? Can we rule out C? Alright, so A and C are possible. Everybody follow that? Now, when you do the high dose dex, it's not going to, if it's a tumor, it won't bring it back to normal levels, but it should suppress at least a minimum of 50%. And so that baseline cortisol was, what was it, 10? Is 9.5 50% of 10? No. Well, you draw another blood sample from Scooter and submit the properly handled sample for endogenous ACTH level determination. Yes, sir.
We didn't rule out A because...
Didn't rule out A because right now, because we didn't get any response to the suppression period.
From the high dose.
Right.
Okay.
So, we didn't rule that out, and we didn't rule out a tumor up here that's not responsive. Because if it's adrenal, is it going to care less about suppressing ACTH? So that's why with the high dose dexamethasone suppression, you don't see any or minimal response as far as something down there. Clear? All right. So what do so what we do a endogenous ACTH. Scooter's endogenous ACTH level is 30 times normal values. So put all your results and findings together. What is your diagnosis? Can we rule out primary? If we had primary, would that suppress ACTH production up there in the pituitary? So what would my endogenous ACTH be? Low. Is it? So can we rule out